I'm Tyler Hughes. This is my wife, Hillary. I'm on the board, and my wife and I and a few others here started the New York Metro chapter, which was the first chapter here for the foundation. So I hadn't made it to the summit yet, and as a board member, I just wanted to tell you how thrilled I am to see the outcome that we have here, and just to see what's going on in this round table up front, the discussion points. This is just fantastic. So I really look forward to continuing this. And I hope you guys are taking some great content away. So appreciate everybody being here. And my wife is going to talk quickly about Dr. Nicholson. But when in 2013, we lost our son, Oliver. We had no very healthy pregnancy. And we have still really no answers on why. So to me and to my wife, I think that's the reason why we're here and why we're dedicated in trying to figure out a lot of the same things that you are, which is why this happens. And we need to get to the bottom of it in the United States because we're not making traction.
So we're honored to introduce Dr. James Nicholson in Oliver's honor. I'll try to get this all right. I hope I do. Dr. James Nicholson obtained his undergraduate degree from Earlham College in 1977, his medical degree from the University of Pennsylvania in 1981, and completed his internship and residency with the Duke Watts Family Medicine Residency Program in Durham, North Carolina in 1984. Following his residency, Dr. Nicholson joined a private practice in North Grover-Nordale, Connecticut. In 1997, Dr. Nicholson returned to the University of Pennsylvania to join the Department of Family Practice and Community Medicine. While pursuing a master's degree in clinical epidemiology, he published the IPAT system of identifying pregnant women who would benefit from induction before 40 weeks of gestation. The publication was an editor's choice paper in the American Journal of Obstetrics and Gynecology. The AMER-IPAT concept was further developed and followed up with a prospective randomized clinical trial, RCT, of AMER-IPAT. In 2012, Dr. Nicholson moved to the Hershey Medical Center of Penn State University in the Department of Family Medicine and Community Medicine, the Department of Obstetrics and Gynecology, and the Department of Pediatrics. In the last few years, Dr. Nicholson has become increasingly concerned about the rising numbers of stillbirths in the U.S. and has studied the correlation between the 39-week rule, implementation, and the rate of stillbirth. His data was presented at the annual meeting of the Society for Maternal Fetal Medicine in February 2016. Dr. Nicholson is here today to present an update on his continued efforts in this area. His presentation is titled "The Association Between the 39-Week Rule and USA Term Stillbirth Rates, an update and discussion of ethical implications." Please join me in welcoming Dr. Nicholson.
Thank you. Hillary and Tyler, thank you very much for that introduction. And I will be thinking of Oliver during this presentation. So I want to really thank the Star Legacy Foundation for inviting me to come. This is my second time speaking here, and it's really just a great time to meet people and talk about ideas and hopefully make some progress. I personally am frustrated that, at least from my standpoint, I'm fighting a retro battle. Yeah. The rates are getting worse, not better. And that makes me upset. Anyway, so I want to talk about the association between the 39-week rule and U.S. term stillbirth rates. I'm, if you will, even though I'm a family medicine doc, I'm a subspecialist in this area. I'm looking at term pregnancy, which is 37 weeks and beyond. My objectives for today are to describe the rule, the 39-week rule, its history, and the quality of its research basis. Secondly, to discuss the possibility that the 39-week rule may be causing many cases of term stillbirth in the USA today. And thirdly, to consider the 39-week rule with respect to three major medical ethical principles, which are beneficence, autonomy, and justice. Those are just the three basic ones we learn in medical school. I want to close in terms of objectives by suggesting a slightly new model of medical ethics, which is what I call the weighted professional responsibility model of medical ethics, a new concept. So when I was about 5, I had my first theatrical experience with a one line in a play at my high school. I was asked to be the little boy that said, "Mom, he doesn't have any clothes on." And I want to use that concept, unfortunately, with the 39-week rule. And I'll get into that and why I say that. And that's a relatively bold statement. And Roberta will know a little bit about why I asked her for an email. Okay. So definitions. So just so we can speak together and understand this. Early term pregnancy is 37 weeks to 38 and 6, 2 weeks. Full term is now 39 to 40 and 6. And late term is 41 to 41 and 6. And those are important definitions because the 39-week rule impacts the early term period. Induction of labor, what is that? It's the initiation of labor by artificial means. We're going to get someone into labor rather than waiting for her to go into labor on her own. An indicated induction is a situation where the risk-benefit ratio for delivery now clearly outweighs, and I mean clearly outweighs, the risk-benefit of waiting until later. Okay, so we have a real reason to induce now. And these are the indications that are now accepted, just a short list of them. Severe preeclampsia, you can go down the list. These are nasty things that can happen during the late preterm or early term pregnancy. And the issue is that they're all major problems. These aren't mild things, these are major problems. And they give us the excuse to induce a labor even before 39 weeks. But again, they're major problems. A non-indicated induction, in contrast, is a situation where the induction occurs in the absence of an indication. That doesn't mean that there aren't risk factors. It just means that there isn't a reason on that list that I just showed you. And it's often called an elective induction. Even though there might be good reason to do that, it's still called an elective induction. So these are just the short phrases I may use during the talk. Indicated induction is IIOL. Non-indicated is NIIOL. We good so far? Okay. So there's the 39-week rule. This is a strict clinical guideline currently enforced throughout the United States that states that a non-indicated delivery should not occur prior to 39 weeks, 0 days of gestation, i.e. not within or before the early term period. That's the 39-week rule. And by the way, I apologize to the folks that aren't U.S. here, all the internationals, because I know you guys are looking at me like, why are we talking about this? This is an internal U.S. discussion. Okay, so in my career, I've had the absolute honor of being able to talk in different countries. I've been to Norway, where there's King Harold V, and I've been to Australia, where there's Queen Elizabeth, who still, I think, has some connection to that wonderful country. I've been to the Netherlands, where there's King William Alexander. So these are examples of kings or emperors or queens. And then we kind of have our own U.S. folks that aren't quite emperors yet, but maybe someday. But we do have institutional emperors, if you will, ACOG, March of Dimes, Joint Commission, Medicare and Medicaid. These are important structures that guide us and help us in medicine. So these are emperors and kings and queens. But some of those, and specifically I'm talking about the 39-week rule, may be an example of the emperor in this little story that you all know about. This is the emperor, I think, looking in a mirror. I would add that there may be different ways to interpret this if you really wanted to. There may be some fake news here. Is this the emperor looking out a window at one of his subjects who actually doesn't have clothes on, or is, what exactly is going on here? So there are different ways to interpret. But I think the 39-week rule is the potential to be an emperor without clothes on, and again, that's a bold statement. So I want to take a careful look at the 39-week rule with you. I want to look at its basis, its apparent impact, and its concordance with modern medical ethical principles. Okay? So induction's been around a long, long time. There are reports of it way back in 100 AD, and up through the centuries there have been different things that have been done. There's a book in 65 by Fields, Green, and Smith that describes that history. There have been recently in my career modern improvements to labor induction, so it's now more effective, safer. We got Foley bulbs, we've got prostaglandins now of different sorts, which really make induction of labor when you would like to do it for good reason possible. And ACOG, American College of OB/GYN, has been talking about labor induction and how we should use that or not use that for a long, long time. So this was actually a publication they did in September of 1979. They were talking about induction because people were doing that, but they said due to the imprecision of LMP for pregnancy dating, a non-indicated delivery without really, really good reason should not occur until at least 39 weeks, 0 days. So there you have, even back that far, 39 and 0. There was another publication that happened a number of years later that basically said kind of the same thing, only do it for indications. But the indications included at that point logistic factors and psychosocial issues, so you could kind of listen to a patient and decide to induce. But to ensure fetal maturity, an induced pregnancy should be at least 39 and 0. So again, 39 and 0 is being used. When you look at that publication, and this is where I'm going to start to be critical of the rule, when you look at that publication, the bibliography contains 34 citations of articles, but no level 1 evidence. For those non-scientists, level 1 evidence are randomized clinical trials where you basically take someone with an issue, you flip a coin and you treat her, in this case her, either one way or another way. You get enough of them in your study, and then you can find out which is the best method of treatment. But this publication way back in 1995 contained no evidence based on RCTs. In 2009, there was an updated bulletin. It's called a practice bulletin. And it stated in 2009 that induction should be performed only for indications. We got that. The list of indications included logistic factors like being far from a hospital or psychosocial factors like depression. And it stated emphatically that the list was not absolute. So the list of indications were there, but you could break that if you would like to. And states that in order, again, to ensure fetal maturity, induced pregnancy should be at least 39 weeks, 0 days. So again, the same phrase. Even though we now have ultrasound that's more properly dating pregnancies, and probably we have better NICUs to take care of babies, and relative prematurity isn't such a big deal. But we're still looking at 39 and 0, and I'll talk about why that is in a few minutes. Of note, the bibliography of this bulletin had 90 references, and it contained multiple observational studies, retrospective studies, and just one RCT within its publication by a lady by the name of Mary Hanna. But that study actually showed that induction of labor at 41 weeks provided you with better outcomes than waiting until later than 41. But it was the only RCT in that publication. So that's where we were, about 8 years ago. Right after that was published, there were a series of articles that all of a sudden got stricter. And these are a few of them, but there were a number of them that basically started to say that, hey, if you really look at the term period of pregnancy from 37 to 41 weeks, that things aren't so good in the 37th and 38th week, and maybe labor induction isn't so good anyway, so maybe we should be more strict about this 39-week cut point. There's an article published in late 2009 where they talked about elective delivery prior to 39 weeks, which we're already talking about as being a bad thing, as a case of the normalization of deviance, kind of a strong word. Normalization of deviance is a term used to describe the phenomenon in which individuals unknowingly persist in detrimental patterns of behavior based on a low frequency of individual adverse experience. So if there's a rare outcome, but someone's doing something that might not be so good, he or she might not know that they're doing that, and especially if they're not listening to what the experts are recommending, he's deviating from the standard of care and not doing a good job. All right? So that got into the issue, that article, that to induce before 39 weeks without an indication was unprofessional behavior, not a good thing. The California folks got a hold of it, and there was a large, what's called a toolkit that was published that talked about eliminating non-medically indicated or elective deliveries before 39 weeks. So there was really a groundswell to stop people from doing that. So that really swayed public opinion. This became a national issue. Then the Joint Commission, which is the body that kind of supervises hospitals and regulates them and makes sure they're doing okay, they got on board saying, hey, this is a quality issue. We want to make sure that people are following this important rules. This became a hospital certification issue. So in this day and age, hospital administrators have a lot of power in terms of what practices are done. So they were saying, hey, you can't do that physician person who you are, because if you induce before 39 weeks, we'll get dinged by the Joint Commission. And then CMS got involved and funding agencies got involved saying, hey, if we know this is so bad because of all these other things, so we won't pay you if you induce before 39 and 0. So how many inductions for non-indications do you think were going on after a couple of years of this? Not a whole lot. That's the 39-week rule, which was adopted or imposed, or whichever word you want to use, in 2010. It became a strong thing. And my concern is that no one was saying that this rule doesn't have any clothes on, that it's not a good rule. So I want to look at specifically the rule in terms of two key things with it. One is observational studies of outcomes following labor induction, because labor induction itself has kind of a bad word, is a bad word. The second is looking at observational studies of neonatal outcomes, baby outcomes, as a function of gestational age during the term period. All right? So observational studies of outcomes following labor induction. Excuse me. So there were literally hundreds of studies that were done in this exact format. So comparing non-indicated induction of labor to spontaneous labor. So it's easy to do. You take any hospital in the country, you go back 10 years, you look at all the ladies that were induced, compare them with all the ladies in the term period that had spontaneous labor, and you see what the outcomes are. And these studies always show that with non-indicated induction of labor, there's more C-section, more NICU admission, and more what I call stuff, just more bad outcomes. So clearly we're being reinforced to say that induction of labor is bad, and you shouldn't do it unless you have to. Problem is there's this thing, and I'll talk with the scientists here, but everybody else too, there's this thing called confounding by indication, which is if something happens that makes you do an intervention, and then you get bad outcomes. Is it the intervention that causes the bad outcomes or the thing that made you do it in the first place? That's called confounding by indication. And I think it's clearly at play here because there's more risk in the folks that were having non-indicated inductions. They were called elective, but I know from personal experience that we didn't induce people usually just because we wanted to, or because they're heavy, or they were short, or they had borderline hypertension, or they had stuff, risk factors. That's why we were doing these pre-39 week inductions. There are bad apples. There are people that would induce just for the heck of it for their schedule, but they were fairly rare. Second issue, which is key, is what's called improper modeling. So if you really think about the situation, if you're sitting in your office with a pregnant lady at 38 weeks, 0 days, and you want to decide how to care for her, you have a choice maybe to do a non-indicated induction of labor. But your other clinical choice is not spontaneous labor. It's expectant management to a later gestational age. So you can choose to either induce now, non-electively, non-indicated, or wait till later. And if you follow expectant management, there are 3 ways that lady's going to get into labor. Spontaneous labor most of the time, but she may also develop an indication for induction, which is linked with higher risk, or she may develop something that just requires her to have a C-section because the risk is really high. So very different from comparing induction to spontaneous labor. It's induction to expectant management. So if you do the studies, if you go back Next best is 40, next best is 38, next best is 41, and 37 or 42 are about the same. But there's clearly an optimal time, which is 39 weeks. What the studies then do is they take a dotted line, arbitrary line, and they dot it right at the start of 39 weeks. And they say, those babies that are born after that do better than those babies born before that. These are the kinds of things that those studies have looked at. And they keep coming out. If you look at the literature, they continue to come out. 39 weeks is the ideal time. My problem with these studies, when you look at them from an epidemiologic standpoint, is that it's an arbitrary cut point. You take, for example, 39 weeks, you put every baby that's born at 39 weeks into a 39-week box, and you draw that line, and you're basically saying within the study that a baby born at 39 and 0 is the same as a baby born at 39 and 6. And a baby born at 39 and 0 is very different from a baby born at 38 and 6. 1 day difference makes a big difference. 6 days, that's the same. These studies don't look at outcomes as a function of day of gestational age, which could be done. They just put them in boxes. Not only that, but the studies often will combine 37 and 38 weeks together. So now you're talking about a 2-week block as compared with after. And some of the studies that have been classic and really used to formulate our opinions included 35 and 36, the late preterm babies with the early term babies, to say, hey, this group doesn't do very well. We should not allow this to happen. And I don't think that's fair science. There's also selection bias that's occurred. That's a medical term. But there are some studies that were done with that same kind of block formation on babies that were electively sectioned, not allowed to go through labor like with induction, but sectioned. And we know those babies don't breathe as well as babies that have labor. And yet those studies were used to generalize to babies that would be induced. And there's the same issue with odds ratios and relative risk. The statistics aren't enough to claim causation. And the two examples well, let me show you this. So the key point with this is that this is an example of what I call, what is called the ecological fallacy. These are ecological studies, studies of what is. You put babies into these blocks and you measure what is, okay? Ecological fallacy basically means the measurement of what occurs naturally cannot be used to definitively predict what will happen after the intentional alteration of the natural order. Holy mackerel, what a phrase that is. I'll give you two examples, okay? I have two teenage daughters that are 16. They're about ready to get their driver's licenses, all right? The rate of accidents for teenage drivers is higher at 16 weeks than 17 weeks. And it gets a little bit less at 18 weeks. So as a politician, I'm going to say, okay, well, listen, the answer to this is let's not let 16-year-olds get a driver's license. Let's make them wait till 17, because look, the rate's lower. All right? It's not going to work because part of the reason they're having their accidents when they're 16 is that they're learning. So you shuffle them into 17 weeks, they're still going to be in that first year of learning. The other great example is, you know, the old man who's very, 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 very wealthy in a city goes to a very smart guy who says, how can I live forever? Right? You guys know the answer to this story? The answer, the smart guy says, is move to the ghetto. Because there's never been a rich man who died in the ghetto. It's an ecological cohort study of the city, and it doesn't work to take the rich guy and put him into the city. But that's the ecological fallacy. And what the ecological fallacy is that you can't go from the studies that are published to say that if you do this translocation of patients from 40 weeks, 39 weeks into 38, 37 weeks, that you'll necessarily get the outcomes that are as bad as what you see naturally in the 37th and 38th week. You don't know what's going to happen when you do that, but you can't say that you know what's going to happen when you do that, and that's kind of what's been done. And the only really good way to find that out is, again, to do a randomized clinical trial where you randomly assign people either to maybe delivering the 38th week versus waiting till the 39th or 40th. So I'll do a little plug for my own research, which is the association between the regular use of preventive induction, often in the 37th or 38th week, more in the 38th week, to improve birth outcomes. And I actually have had several studies. We published a review or meta-analysis of that back a few years ago. The Amore IPAT group, that's my group, had total of 1,153 women exposed to the active management of risk. That meant they were induced more often preventively or electively for risk, but they were induced without indications, versus the usual care group that had 1,865 women, had a lower overall induction rate and a low non-indicated induction of labor rate. And these were the outcomes. So the section rate was 5.7 versus 14. The NICU admission rate was 2.9 versus 6.5. And the AOI score, which is an adverse outcome index score, it's kind of stuff of labor, was significantly lower in the actively managed group. So when I did more elective preventive inductions, often breaking the 39-week rule, I got better outcomes. Most of those studies were retrospective, and I'll be the first one to say I can't draw conclusions from that. But that's what the data showed. But around 2010, here comes the 39-week rule. I can no longer do what I used to do, and it's frustrating. So the 39-week rule was adopted or imposed in 2010, and there are a couple of questions I want to ask. Has it been successfully applied? We created it. Has it worked? And there are a whole bunch of studies that show, yep, definitely has worked. There are fewer births that are born. There are fewer overall births prior to 39 weeks in the U.S., and there are dramatically fewer inductions that are done without indications. Has there been a reduction in the U.S. primary C-section rate? Yeah, there's been a slight reduction. Not sure if that's due to the rule, but there has been a reduction, which I think is good. Has it reduced NICU admission rates? So if we think we're going to be shifting babies upward with the 39-week rule, now they're going to get bigger, theoretically healthier. Would the NICU admission rate go down? One small study started to say, yep, it looks like it lowered our NICU rate, but then the larger studies came out, including one that looked at national data, and the answer is actually no. Actually, the NICU rate in the U.S. over the last 6 years has gone up, not down. In-term babies, I would add. How about maternal mortality rates? What's happened to the maternal mortality? That's gone up, actually, over the last 10 years. I will definitely not claim that the 39-week rule has caused that, but still that trend has happened during the time period. And you know, this is a stillbirth conference. What about the rates of term stillbirth in the USA over the course of the adoption of the 39-week rule? Well, it's an important question to ask. And you know, going back historically, I get a little bit annoyed with my medical profession, because here's an article, 2001, by someone who's very, very well known in the OB field, Gordon Smith, who published an article, Life Table Analysis of the Risk of Perinatal Death at Term and Post-Term in Singleton Pregnancies. And basically he's measuring what's called the cumulative probability of antepartum stillbirth as a function of gestational age. And he said, hey, the cumulative risk increases as you go through term pregnancy. The further you go through term pregnancy, the more likely you are to have a stillbirth. And these are the numbers from his study. So at 37 weeks, it's 0.4 per thousand, gets progressively larger, up to 11.5 if you go to 43 weeks. So there's clearly a biological something going on. And the problem with the 39-week rule is that it shifts patients in our population from the lower risk strata or groups into the higher risk strata. And we don't know what that would cause, but there's at least a biological plausibility that it might be increasing the stillbirth rate simply by making women gestate longer. There was an initial paper that came out in 2011 out of Delaware that showed, yeah, when we did this rule, our rate increased by quite a bit, 2.9 per 10,000 up to 9.1 per 10,000. There was some initial data out of states like Minnesota showing, yep, the stillbirth rate seems to be, term stillbirth rate seems to be going up. But there were several studies that found no association between the rule and higher rates of stillbirth, and these got a lot of press, and people were, if you will, relieved to know that even though they were using this, well, they were using this rule, they thought it was good, multiple bodies thought it was good, and there was no apparent increase in the rate of stillbirth. But no one was looking at national data. No one was really looking at the global picture. So there were no large studies. So partly because of my involvement with Star Legacy here and my concern about the rule, I talked with the folks in my department at Penn State, and a couple of the residents got excited, and we said, why don't we ask the states for their data on the timing of birth, how many births they'd had total, and then how many stillbirths had happened in their state over a 7-year period, 3 years before, 3 years after 2010, and figure out what exactly has happened in the U.S. This is just a graphic demonstration that the 39-week rule really did work. So on the left is 37 weeks. That stayed about the same, but 38-week births decreased over the 7-year period because we're not allowing non-indicated induction. The frequency of birth in the 39th week went up quite a bit. Interestingly, the frequency of birth in the 40th week went down a little bit, and also in the 41st week went down a little bit, and 42 stayed about the same. But clearly there's a movement of birth from the 38th week into the 39th week. This is a graph of the rate of stillbirth by year, just the total rate of stillbirth. And if you look at the dots, you get a general sense that there might be something going on with that. That's a bigger version of the same graph. If you put a cut point where the rule was started, it's right there. And then if you draw a regression line, if you do the math to figure out what the line is, you get that, which is, I think, suggestive of an increase. And when you crunch the numbers, there are 3 million term births in the U.S. at that rate of increase. It comes out to be about 400 additional term stillbirths a year. Not good. That study was presented at Maternal Fetal Medicine back a year ago, was fairly significantly criticized. The data I have always admitted is crude, but people really were skeptical that this really showed something. And I was at the conference that happened just this past January, where another study was presented based on better federal data. This is now coming from the NIH, not the NIH, the CDC. And this is from the COE group out in Oregon. And they too showed that there was an increase in the term stillbirth over that interval from 0.09% to 0.10%. If you crunch those numbers, 3 million births, they got about 300 additional term stillbirths per year. Now, we can't claim that there's a cause, right? I will be very honest about that. You can't claim there's a cause. But there still has been an increase, and I'll get into why I'm extra concerned about that in a minute. But that same study also reported that the infant death rate went down during the same period. Not by a little bit, but by quite a bit. So those are the numbers. And if you crunch those numbers, that's 900 fewer infant deaths per year. This is in the first year of life. And if you're really good at math, you'll find out that plus 300 minus 900 equals 600 lives saved. And this was presented as a reason that the 39-week rule was okay, that we should continue to use it. And I disagreed, and I asked a question and actually got in kind of trouble for asking it, but I asked it anyway. I think there are other reasons that the infant mortality rate went down. And I'm a practicing family doc. I've seen these things happen. So back to sleep programs, avoidance of co-sleeping, shaken baby issues, infant car seats, pertussis immunizations, greater access to care, health care through the ACA, lower threshold for NICU use. All those things I think have a significant impact on infant mortality. And I'm not so sure that the 39-week rule caused that. And my question was, if that's the case, if these other things made for the infant mortality decrease, which is good, then we're still left with a 39-week rule potentially causing an increase in the term stillbirth rate. So maybe that's what we're left with. What would have happened to the U.S. term stillbirth rate during the same period of time if Sleep on Your Side advice hadn't been out there, and if there hadn't been this shift to deliver more ladies in the 40th week, because they got flipped to the 39th week also? Those factors would have by themselves decreased the stillbirth rate, and yet the rate still went up. What do we do with evidence that pregnancies with certain risk factors that are not indications for delivery may have an optimal time of delivery in the 37th or 38th week? Because there's good information about that. What do we do in the early term period when maternal intuition suggests that there's something wrong? Sorry. A year ago at the ACOG annual meeting, 2 debaters were going to debate the question, should we induce everyone at 39 weeks or should we wait till 41? Okay? Classic debate. And, you know, it's been thrown around for a long time. I think it was looked at as probably a boring debate. You're going to go through the same stuff. These two guys I know, Norwitz I've actually spoken at a stillbirth conference with. He's a great guy. Charlie Lockwood was my med school roommate. Yeah. These guys are both brilliant. They're both leaders of their field. They're both chairs of departments. They both said that everyone should be induced at 39 weeks if you wanted to maximally improve outcomes. Lower section rates, lower NICU admission rates, lower stillbirth rates. So we haven't heard much of that since the debate. It's been quiet. But if everybody ought to be induced at 39 weeks, if people with risk factors are out there, it seems like they should be induced earlier, even if they don't have an official indication. So, Roberta, here's your mole slide. My problem with the mole slide is that when I was a kid, I went to amusement parks, and there's this great game called Whack-A-Mole. Yeah, okay. So there's the 39-week rule. You stick your head up, and you make a noise about stuff, and you may get whacked. So briefly, medical ethics. Let's talk about medical ethics for a minute. These are the three things: beneficence, non-malfeasance. I'll explain these in a minute. Autonomy and justice. So beneficence is, as a physician, as a provider, we're obligated to treat our patient with skill and knowledge and be good at what we do and advise them and treat them in a way that's as excellent as we can possibly do. Ideally, especially in this day and age, it's based on really good evidence. But that's what beneficence is. And then non-malfeasance is directly related to that, and that's the idea that above all, we should do no harm. So if we don't really know what to do, we shouldn't do something that might hurt somebody. But our obligation to patients is to treat them as best we can. Autonomy, on the other hand, is the patient's right to either request or refuse treatment. And it's really essential, and ACOG talks about that a great deal in some of its literature, that women ought to be able to be given the choice to decide what their health care will be like. Okay? And often those two things are in conflict, because a physician provider will feel strongly about one thing and a patient will feel differently and have her own set of values. And so often there's a conflict. Get back to that in a minute. And the third one is justice, which is we ought to treat everybody kind of similarly, and we ought to use resources wisely. One of the things that induction of labor has been criticized for is that it might cost more than waiting for labor to start on its own, or expectant management. The poster I had at MFM this year said, no, when you induce, you get better outcomes, and that saves cost. Even though it costs more to get you there to delivery, the cost downstream are less. So I don't think justice is part of this conversation. There's this thing called the professional responsibility model of ethics in perinatal medicine. Cheverniak is one of the authors on this. And it kind of has to do with reframing a little bit the idea of beneficence. So a provider of medical care should commit to, these are important things, becoming scientifically, clinically competent, using his or her clinical knowledge and skills primarily for the clinical benefit of the patient, and preserving medicine as a public trust and not a self-interested guild. So you shouldn't be doing things or following things or making things for the benefit of your profession, but rather you should be directed towards the patient, which I think is a great idea. Reliance, however, on evidence-based clinical guidelines is stressed, and deliberative clinical judgment, big long phrase, is used to responsibly reduce uncontrolled variation in clinical judgment and practice, thereby improving the quality of both. So we have clinical guidelines, ideally that are really well done and evidence-based, that tell us how to practice so we can take the best care of people. And ideally, doctors ought to follow that. They ought to do what's best for their patients. In the paper that this was described in, it had to do with an early term induction of labor. And where this model came down, in his opinion, was, that's not a good idea. It leads to higher section rate, which it doesn't. It leads to other complications, which we don't necessarily know that it does. But that the physician would have every right to say to a lady who wanted an elective or non-indicated induction, no, you can't have that. The problem with what he describes is it requires that the guideline that he's using or she's using is really solid in its evidentiary base. And the 39-week rule doesn't have that. So what I propose instead is just to think about it as what I call the weighted professional responsibility model of medical ethics. So in this kind of seesaw, you've got provider issues with good evidence, good standards of care. And patient issues are there, but she may be somewhat ambivalent, and in that case we're going to go, I think, with the provider because there's good evidence there. On the other hand, if the provider issues aren't as strong and there's borderline evidence, I think, as in this case, but the patient issues and beliefs are strong, then we ought to listen more carefully to the patient and provide her with the autonomy that we talk about. One of my last slides is, whose baby is it anyway? This is not a simple question, okay? It really isn't, because as a society we have responsibility for a baby, and Treviniak in his talk talks about the baby as a patient, and he has obligation to the patient and do what's best for the patient, and that's true. And nurses and doctors and hospitals, they care about the baby. But I think the bottom line is the baby is the mom's. But don't think that other people don't have a vested interest in making sure that we treat that baby, your baby, whose ever baby, with as good care as we possibly can. So 39-week rule reflects long-standing tensions in optimal management. It's not well supported by high-quality research. Clinical trials are not there to support it, but it's still the law of the land here in the U.S. It's not been associated with a major change in national section rate. It's not reduced the NICU admission rate, apparently. It may probably have led to an increase in the number of cases of term stillbirth. Again, I can't conclude that, but that seems to be likely based on the biology of pregnancy. And it can't be used to justify the principle of beneficence because the quality of the research I don't think is there. Well, I'm going to go back to that one. The issue of non-malfeasance, above all do no harm, which we hear about all the time with reference to induction, unfortunately was not applied to the 39-week rule. The rule was not imposed at the time that people were saying, hey, this might cause a problem. This might cause harm. It was just imposed. And that too is a problem. And then the imposition of the 39-week rule, especially in the setting of strong patient beliefs, is really in conflict with the concept of autonomy. If a patient wants to be induced at 38 and 6, which is 1 day from 39, it doesn't make scientific sense. It's the law of the land, but it doesn't make sense from the standpoint of either science or autonomy. And then consider the use of a weighted professional responsibility model. I think Alex talks about that in England, where you have discussions and you can weigh the benefits and the risks, and you could give advice, but you can also be flexible with how you respond to pretty strong questions. So I would argue that in the case of a woman who really wants, for good reason, intuition, significant risk factors, that if she'd like an induction prior to 39 weeks, but doesn't have an actual indication, that she should be able to have one. And somehow I'm going to have to figure out how to be a mole and stick my head up and challenge it. But it's dangerous. Maybe if there are a number of moles all sticking their heads up at the same time, the operator of the mallet won't be able to get all of us at the same time. So thank you for your attention. I'd be happy to answer questions.
Thank you, Jim. All right, we'll turn it over to Q&A. How about from the panelists first?
Thank you so much. I really enjoyed that talk. I'm wondering if there isn't a way to kind of dissect this out more by looking at all the different variables, including fetal sex, including other factors that could potentially dissect out who is at higher risk, who we can. I think you talked about this before. Different ethnicities, for example, that this rule may not apply to. I really feel like there should be more data to be able to convince people. And then the other thing that we're finding more and more, and there's papers coming out where they're looking at the molecular sort of features of the placenta and showing that the placenta, there's a placenta clock, and that it may not be the same for all patients and all placentas.
Sure. So I agree with you 100%, and I'll give you two examples. One is that there are more and more papers in the literature that African American women have a due date that's probably a week before that of Caucasian women in the US anyway, and also in Europe. So if that's the case, then the 39-week rule for African Americans should be a 38-week rule. But we don't do that. We still apply the 39-week rule. And the second example is that classically, and I've never actually read a paper, but classically, boys are wimpier than girls. And therefore, we ought to be able to sex a baby at ultrasound and maybe modify our concern about the timing of delivery based on fetal sex, not as the main factor.
They're wimpier, but they suck the life out of their placenta much more so than
You learn something new every day.
shown over and over.
Yeah.
They just don't know how to control themselves.
So, but in all honesty, there's this huge balance, or this huge issue between having physicians do what's best all the time, so quality and conformity, versus the concept of individualized care, which is especially becoming big in the genomics field. And those two aren't easy to mesh, but I think ideally we would find a way to do that.
Alex?
I wonder whether an alternative approach is to address the list of indicated reasons, because that also seems to me to be, not quite right. Because I think aside from what gets bracketed as non-medical indication, so for example, what would happen if you've presented 3 times with reduced fetal movements to your care provider? Does that count as medically indicated or not medically indicated? Because my understanding is if it's not on the list,
Right.
it's not. Now, I mean, say to my mind, it is an alternative strategy to say, look, your list isn't right. If you want to have medically indicated things, because the odds ratios for term stillbirth for many of the things that are on the list are modest. So, I mean, I haven't said the list in detail, but say obstetric cholestasis, most people would say is an indication for induction of labour at 37, 38 weeks. But that's got an odds ratio, its odds ratio for stillbirth is somewhere between 3 and 4 probably. So, and that is the same, or perhaps even less, than recurrent reduced fetal movement. So to me, an alternative method of attack is to say your list isn't right.
So I agree with you, but I would add 2 things that get back to my work and what I call a more IPAT, which. So the problem is that some people have multiple risk factors. They don't have just one, they have like 3 or 4, and you treat that person the same as somebody who just has one of those that aren't on your list. So you have to, in my mind, have a way of modeling that to account for the variation that exists clinically. And the other thing is, yes, you can have a list, but perhaps the things on the list ought to have different gestational age. And ACOG does that. I mean, there's some things that will buy you now an induction at 38 and others at 37. So there's some variation that occurs, but I don't think not enough. Yeah.
Just to come back on that, I think that's a really good point. I think that I've been involved with our antepartum confidential inquiry, and actually what struck me in sitting through those cases was the people that miss thresholds by very small amounts. So, someone who's 39 years of age, who's got a BMI of 34, whose blood pressure is not quite 140 over 95, actually their cumulative risk is probably much, much greater than someone that takes a single one of those out. But yet, because they never cross anyone's threshold.
And I know we're running out of time, but I know we all hate this computer, because it's been misbehaving all day. But one of my frustrations with the field of OB is we don't look at risks like Alex is describing as continuous risks. We look at them as dichotomous. Either you have it or you don't. And that's not what biology is like. So we have these computers that could do all kinds of wonderful interactive modeling, but we just haven't gotten to the point of doing that. And that would be a huge break from where we are now in our country with how we approach OB activity. But that doesn't mean that it's scientifically invalid and might give us benefit. Sorry.
Can you pull up the slide with the 7?
7 indications?
Yes. I just wanted to ask you the slide.
I was just going to say that we do have quite a lot of information about risk factors for stillbirth, particularly at term, and there's American data and there's also information from Vicky Gennadi's systematic review, etc. But what we don't know is how those various risk factors interact with each other and whether a combination of them, whether they multiply, whether there's a different relationship between them. And one of the things that we're going to be able to do with our individual participant data meta-analysis from all the case control studies that have been done looking at sleep position is we've also got very rich information about a whole bunch of other demographic risk factors. So we're going to look and see if we can build clinical risk sort of prediction scores by looking at these various parameters and look at preterm and term stillbirth. And currently, your barn door average clinician doesn't look at the woman in front of them, at 39 weeks, for example, who's and think about her BMI and her age and factor that in very well,
Right.
etc.
And to do those studies, you have to have a really good database that collects
You do.
really good
Yeah.
information so that you can do the modeling.
Detailed information rather
Yeah.
than the hospital data.
I know we're over time.
No, we're okay, Jim.
We can take a
Okay.
couple.
Okay.
Yeah. So a couple of popular questions here on the app, Jim, are around adding reasons for an early induction. One comment is it seems odd that one of the indications for induction of labor isn't a previous stillbirth. And then a similar question was, how do you go about adding an indicator to the 39-week rule? And also, what about advanced maternal age for early induction? Is that one of the factors?
So it's not on the list. It does buy you sometimes additional testing, which might find an abnormality which can get you delivered a little bit earlier. Uma, you might know better than I to answer that question. How to add additional indications and whether those other indications are on the list of indications.
Right, so advanced maternal age is a huge topic.
Yeah.
Okay. Yeah, advanced maternal age is a huge topic since 15% of the U.S. population is over the age of 35. And actually, Jim, I don't need to give half my presentation because you did it today practically, which is good though. It's
Sorry.
good. Oh, no, it's okay.
You'll do it
yeah,
better.
Yeah, I mean, so in terms of, I think everyone's in agreement that, there is a constellation of risk factors. These things cannot be taken in isolation. And it's just, like you said, bewildering how these decisions are made. A decade ago, there were a lot of early term births. So early term was defined as 34 to 36 weeks completed in the U.S. That was called early term. And it was clear that there were a lot of births being done in that period because of, no real indication, and doctors were accused of, just doing it out of their own convenience and causing morbidity. So then that got renamed as late preterm, and then we came up with this early term. But I completely agree with you. We have good data. We've looked at 37 and 38 weeks, and they are so different. We looked at consortium of safe labor. We looked at 200,000 pregnancies, low-risk pregnancies, and 38 is very similar to 39, and 37 is not similar to 38 and 39. So just, the lumping of those 2 weeks together is not a good thing. But in terms of, advanced maternal age, it's, there was just a study published in New England Journal that showed, it was for women over the age of 35, induction versus expected management. And they didn't show a difference, but, it was, the sample size has to be large to show a difference. We're actually doing a trial, which I'll present tomorrow, with the outcome of stillbirth and severe neonatal morbidity. So I'll talk about that tomorrow. But in terms of getting indications added, the case of recurrent decreased fetal movement, that, you have to individualize. That clearly is not a low-risk patient, and that would not be considered, if you induce that patient, that's not considered an elective induction.
We got
on that same topic, there was a study done recently, and I can't quote anything from it, other than once you turn 35, the risk, so like a full-term birth is 39 weeks. Every age you go up from 35, that decreases 1 week. So if you have someone who's 30 and goes 39 weeks, and you take someone who's 35 or 38, that would actually go down to 36 weeks to factor in all of the maternal. Do you know what I'm saying?
For delivery timing?
Yes.
Okay.
So like, as you get, every year you get older, the risks increase as such that to make them comparable, that week, the number of 39 weeks would decrease by 1 week for every age you are over 35.
So you're making even me a little bit nervous when you talk about 36. But on the other hand, we don't have research to tell us whether or not that might be a good idea. And it very well might be a good idea. I would add that one of the really hard parts about this whole topic, and Uma can support me, is that researching pregnant ladies is really hard to do from an ethical standpoint, because how can you randomize a pregnant lady? The comeback to that I say is, if you don't do randomized clinical trials, experiment on pregnant ladies, you're not going to make progress in terms of how best to treat them. And just in terms of induction of labor, I've never had any trouble finding women that would be interested in being in such a trial. It's more the providers and the institutions that have some legal liability with even trials that cause there to be issues.
Well, I wish we could just work together, because when we started this trial that I'm going to talk about tomorrow, expected management at 39 weeks induction versus expected management, I have to say I got a lot of, I would call it upset people. First of all, why are you interfering with the natural process? Why are you inducing women who have, low risk? And complaints about oxytocin, and it's associated with autism, all sorts of, and it's kind of died down, but do you face, there's a whole world out there that they're very upset about, inducing women and interfering. Parents? Oh, both, but parents, yeah.
So yeah, it's worldwide. I worked with a group in Italy that took my method and ratcheted it up to Italian style, and they were inducing most of their ladies in the late 37th week, and they ended up with a C-section rate of around 4% and no stillbirths, and their colleagues were running along with a section rate of 46, and they had 2 stillbirths out of, I think, 200 babies, late-term stillbirths. And shortly after we finished that data collection, they were told that because the U.S. is not allowing this kind of activity, that you have to stop, and so they had to stop. But it's a worldwide thing that pregnancy is natural, normal. We shouldn't intervene unless we really have to. And the question is, somewhere in between there is a gray area where we might do more.
What role or how big of a role, sorry, right here. What role or how big of a role do insurance companies play in the decision to hold off until 39 weeks for a C-section or for induction?
Just recently, when they've responded to I think the messages from other areas, and they see that as a way to limit paying for something. I don't see them as drivers. And again, my limited financial analysis is they're not saving money by doing that. They may be thinking that they are, but I don't think they really are. And if it is a little bit more expensive, I think the benefits are worth that limited increase in cost. But they're not the main drivers. It's more providers, I think, in society.
So I want to follow up on a question that was asked at the very beginning, and piggyback another question onto it. How does one go about adding something to that list? And the second question is about coming back to your idea of patient autonomy. There's an item on here that's gotten a lot of hits about, from a feminist perspective, this feels like a very paternalistic approach to managing patient care and not giving women and families the decision or the power or the ability to make decisions that they feel best for their baby and for their family.
So I'll answer the latter first.
Yeah.
So that's why I talked about the model at the end, because paternalism has been identified as not good within ACOG, and we should really fight against it. And we need to support autonomy, but then and I'll gently say this, the end run around is to say, yeah, but we have this guideline that's been established, the 39-week rule, which, irrespective of how I might like to respond to you in a non-paternalistic way, the guideline says that this is what the rules are, and I need to follow that to be responsible. I'm not being paternalistic, I'm being professional. And then the reason for my presentation is I don't think the rule justifies, it's not to the level that a guideline should be to
justify
justify that.
autonomy.
Yeah,
And then it comes back to the issue that that Uma's bringing up, is that we, the natural childbirth, alternative childbirthing, industries are also ways to give women or families the ability to have the birth that they want outside of that medical model. And then at the same time, there's this push and pull tension about if you are trying to do interventions, like many of us in this room who may have chosen to have a natural childbirth or sought having deliveries outside of a hospital without high interventions, once the stillbirth has happened to us, there are ways in which we become informed about interventions for prevention that we are upset were not available to us prior, or that we were not aware of prior to our delivery. And so how do we address culturally here in the US that tension between being an informed patient that gets to make autonomous decisions and at clinical or institutions that are basing decisions about our care on things that are not grounded in medicine?
Okay.
And we are at, yeah.
Sorry. Sorry, I know we could continue this conversation all day long, and I apologize because I know there's lots more, and I know Dr. Nicholson is probably willing to answer questions later at another time, but we're already getting into the next presentation, so we're going to shut off. But thank you, everybody.
Jim.
Have a good day, Dr. Nicholson.